في وقت الخوف، وقت ما بنحس إنه مفيش أمل، العين بتروح للي يطمن، البسمة تريح، والإيد بتداوي. مشوار العلم طويل يمكن، بس اللي بيحصل يستاهل. مش ممكن تنسى إنك فارق في حياتنا وحياة كتير غيرنا. فاكر مرة مريض يائس ومعاك خف، فرحة في عينين سمعت خلاص خفيت. طب فاكر مبروك هترجع لحياتك، مبروك هتكمل أحلامك. بس زي ما في حلو كتير في صعب كتير. مرينا بظروف أكيد صعبة، لكنك عديت. كل حاجة مرة بتعدي، بوجودك هتعدي. البطل الأول في حياتنا موجود من غير أسطورة، مش محتاج شكر، ده الواجب، وواجبنا إن احنا في ظهرك سند. ده جميل وهنفضل شايلينه، وجه الوقت اللي نقول لك شكرا. احنا معاك، احنا وراك، لأن اللي بينا كبير.
بسم الله الرحمن الرحيم. مرحبا بكم جميعا في first wave of movement disorder chapter activity. احنا بنتشرف النهارده في الجمعية المصرية للأمراض العصبية والنفسية وجراحة الأعصاب إن احنا ورعاية chapter movement disorder ان احنا هنبتدي اول ويف في الاديوكيشنال كورس بتاعنا. طبعا بشكر بشده اخويا الاكبر العزيز رئيس الشابتر الاستاذ الدكتور محمد سليمان الطماوي، وبشكر الدكتور حاتم سمير على سكرتير الموفمنت ديس اوردر شابتر على مجهوداتهم، مع طبعا الاستاذه الدكتوره حنان عامر على مجهوداتهم في تنظيم هذا الويبينار. بشكر شركة الأندلس على المشاركة في هذا التنظيم، وطبعا بشكر الشركة المنظمة مصر 2000. الحقيقة أنه الموفمنت ديس اوردر تشابتر من أنشط التشابترز عندنا في الجمعية، وزي ما احنا حكم علينا الكوفيد 19 ان احنا نشتغل فيرتشوال، فاحنا مواكبين العصر وشغالين فيرتشوال. بسعد بوجود اخ عزيز وضيف عزيز علينا غالي from Saudi Arabia، دكتور جواد باجوة. Welcome to our webinar. وبسعد بوجود 2 من السبيكرز ان شاء الله يا رب يمتعونا بمحاضراتهم، الاستاذ دكتور وفيق بهناسي من طنطا، والاستاذ الدكتور محمد انور من اسيوط. كل ده يعني الحقيقه يعني بيصب في اناء انه الجمعيه المصريه للامراض العصبيه بتاعت الكل مش بتاعت حد. احنا عندنا اسيوط وعندنا طنطا وعندنا القصر العيني، وطبعا ممثل عين شمس الناشط الواعد الصاعد الاستاذ دكتور علي شالش. فاحنا يعني قصر عيني، عين شمس، اسيوط، طنطا، السعوديه. ودي زي ما قلت فيرست ويف، ان شاء الله يا رب تبقى بدايه، وان شاء الله يبقى في مشاركه من كل جامعات مصر في الويفز القادمه باذن الله تعالى. بشكر الساده الحضور جدا، الحمد لله شايف ان احنا الحضور وصل عندنا لاكثر من 100 بارتيسيبانت، واتمنى لكم ان شاء الله وقت طيب ومحاضرات قيمه. Once again, I want to thank and welcome Dr. Jawad Bajwa from Saudi Arabia, and now I want to give to my dear brother دكتور محمد سليمان طماوي الكلمة عشان يفتتح هذا الويبينار. اتفضل دكتور محمد.
شكرا يا ماجد. بسم الله الرحمن الرحيم. اهلا وسهلا بكم جميعا. Actually, the Egyptian Society of Neurology is now the column for neurology in the whole area, not only in Egypt, in the Middle East. And all the chapters are very active, really, especially the movement disorder chapter. And we have now a network of movement disorders connecting all the neurology department in Egyptian universities, and I hope we will go on, we will continue in our activities in spite of all what is happening nowadays. Welcome our dear speakers, our young speakers, Dr. Wafi Bahnasi, Habib Alwi, and Dr. Muhammad Anwar Al-Aziz. And I welcome Dr. Jawad Padwa, our dear friend. Welcome, Jawad, and I hope it will be a fruitful seminar. And as I always say, always we are in the beginning. We will continue and continue and continue وبكل التوفيق إن شاء الله. And I wish for you all success. ألف شكر. And I give the microphone to Dr. Hanan Amer to go on this seminar. Dr. Hanan.
شكرا دكتور محمد. Good evening, everybody. My name is Hanan Amer. I am a professor of neurology, Cairo University. I am happy to welcome you today in our first quadrantic meeting organized by the Movement Disorder Chapter of the Egyptian Society of Neurology, Psychiatry, and Neurosurgery. This webinar will be held, inshallah, every 3 months. The next one will be on 18 September, and then 18 December, and the last one will be 19 of March, السنة اللي بعدها 2021 inshallah. Our goal with these webinars is to extend and exchange the knowledge in the movement disorder across the neurologists all over Egypt and the world, and to fulfill some of the educational gaps in this field due to the current situation of COVID-19. I encourage you to write your questions in the question and answer, which will be answered inshallah by our eminent speakers at the end of the webinar. Thank you again for joining us, and may I present now the first speaker, Dr. Wafi Bahnasi, Professor of Neurology, Tanta University. He will be speaking about clinical changes in Parkinson's disease-related dysautonomia. تفضل دكتور.
بسم الله الرحمن الرحيم. First of all, I would like to thank the Movement Disorder Chapter and the Egyptian Society of Neurology, Psychiatry, and Neurosurgery for giving me this chance, which is a great honor to share this webinar with my professors and with my eminent speakers in the field of movement disorder. My talk today is about Parkinson's disease-related dysautonomia, which is one of the challenges while we are confronted with a case of Parkinson's disease. The agenda today is about the dysautonomia as one of the non-motor manifestation as a biomarker of Parkinson's disease, effect of dysautonomia and the quality of life, and with the value of dysautonomia in diagnosis of typical and atypical Parkinson's disease, and a small hint about the management of dysautonomia. Parkinson's disease is a multi-system synchronopathy characterized by the classic association of motor features due to dopaminergic neuron loss in the substantia nigra, as well as non-motor manifestations which are due to extranigral accumulation of iron and Lewy body. Parkinson's disease is the second most common neurodegenerative disorders of elderly after Alzheimer. It have a prevalence of 1% of individuals above the age of 60, and the incidence in Egypt is 100 per 100,000 citizens. Parkinson's disease over the 2 centuries have been described as a motor phenomena or a motor disorder, where James Parkinson has raised the issue of shaking palsy, but even at this time, some non-motor and dysautonomic manifestations had attracted his attention, like drooling, dysphagia, urogenital dysfunction, and constipation. Over a time, also Gower have noticed abnormal temperature sensation and sweating in Parkinson's disease patients, and 𝐲𝐸𝐬𝐸 in 1960s have described the cases with late onset Parkinson, which are the 𝐲𝐸𝐬𝐸 syndrome, having late onset Parkinsonism associated with impotence, urinary disturbances, and multiple autonomic deficits. If we are confronted with a case of Parkinson's disease, we have a three scenario. The good way, which is a classic case with typical motor manifestations during the honeymoon period and shows a dramatic response to 𝐜𝐬𝐬𝐷, and this is the easy way. The bad thing is if we are confronted with a case of difficult to diagnose due to atypical presentation or a sluggish response to 𝐜𝐬𝐬𝐷 due to the presence of one of the Parkinson mimics like BSB, corticobasal degeneration, multiple system atrophy, dementia with lower body, or etc. The ugly pathway, which is a case with management of advanced Parkinson's disease case with motor fluctuation and dyskinesia, as well as the management of non-motor manifestations, which are sometimes on the expense of motor management. So the non-motor manifestations can be categorized into neuropsychiatric, sleep disturbances, sensory like olfactory or fatigue or pain disorders, as well as the autonomic manifestations, which will be the focus of this topic today. Autonomic manifestation is one of the most things that affect the quality of life of Parkinson's disease patients, and it represents one of the 5 of top 10 most troublesome self-reported Parkinson's disease manifestations, including the dwelling, the bowel manifestations, the urinary problems, the falls, which is due to orthostatic hypotension, appetite, and weight disturbances. As a whole, all of us, we know the autonomic nervous system consists of sympathetic nervous system, parasympathetic nervous system, and the enteric nervous system, which has a high grade of autonomy. And the enteric nervous system can be divided into the mesenteric plexus, which is the outer and present in the muscle layer of the intestine and involved in the regulation of the gut motility, as well as the submucosal plexus, which is involved in the gut secretion. The first of the dysautonomia is the cardiovascular manifestations. Parkinson's disease has a selective degeneration and lower body accumulation in the long thin unmyelinated postganglionic sympathetic supply to the cardiac plexus, which result in cardiac sympathetic denervation. Cardiac sympathetic denervation in most of cases is present since the early or even the premotor manifestations. It may be presented clinically by malaise, headedness, exercise intolerance, palpitation, chest tightness, fall, or episodes of fluctuation of the blood pressure. The best thing for diagnosis of cardiac sympathetic denervation is MIBG scintigraphy, where intravenous MIBG is injected, and the scintigraphy is measured at 2 times, 15 minutes after injection, which is the early registration, and 4 hours after injection, which is the late registration. The heart-to-mediastinal ratio is measured, and typical Parkinson's disease patients have a low heart-to-mediastinal ratio. So the late form of MIBG scintigraphy has a very high sensitivity and specificity, above 90% sensitivity and 95% specificity, which has encouraged the Movement Disorder Society to put it as one of the supportive criteria for Parkinson's disease diagnosis. It is very important to differentiate one of Parkinson's disease dysautonomia from the multiple system atrophy, which is mainly preganglionic degeneration, and the scintigraphy is usually normal in multiple system atrophy, and this is a positive thing in such technique. MIBG also can differentiate the normal or secondary Parkinson's disease, where when we merge it with the data spec, normal persons have both normal. Secondary Parkinson's disease may have abnormal data spec and normal MIBG scintigraphy. The premotor Parkinson's disease sometimes have normal data spec, but the MIBG is abnormal, while established has both abnormal. So from the third C scenario, we can notice that the MIBG can be present even in the pre-symptomatic and the pre-motor phase of Parkinson's disease. The second thing in autonomic disturbances is the orthostatic hypotension, which is defined as decrease in the systolic blood pressure by 20 millimeter mercury, or decrease in the diastolic blood pressure more than 10 millimeter mercury within 3 minutes of standing or 60-degree tilt table test. Also, orthostatic hypotension can be diagnosed by 24-hour blood pressure monitoring. It is present in about 40 to 60% of Parkinson's disease patients and usually start late in the course and several hours after the onset of motor manifestations. And sometimes it is severe in Parkinson's disease patients where the orthostatic hypotension may persist more than 10 minutes after standing. Orthostatic hypotension in Parkinson's disease is a neurogenic orthostatic hypotension, which is due to postganglionic sympathetic denervation and in consecutive inadequate norepinephrine release in response to upright postural changes. It may be presented clinically by falling, which may be traumatic, and it is sometimes life-threatening. The controversial thing with neurogenic orthostatic hypotension and the challenge is its association with the supine hypertension, which is due to absent baroreceptor sympathoinhibitory response. And it is one of the challenges in the diagnosis because excessive management of orthostatic hypotension may be associated with increase in the supine hypertension, which may lead to left ventricular hypertrophy, renal impairment, and may result in nocturia and nocturnal natriuresis and fluid loss, which may worsen the orthostatic hypotension in the next day. This is a 24-hour ambulatory blood pressure monitoring. And we can notice that the Parkinson's disease patients have nocturnal hypertension, so those patients are termed to be non-dipper. Because normal individuals have decrease in blood pressure during sleeping, but the reverse is present in Parkinson's disease patients. Management of orthostatic hypotension consists of some instructions, including elevated position of the head, plenty intake of fluids and salt supplement, avoid rapid position changes, and slow titration of L-DOPA, as L-DOPA one of the provocation or may increase the orthostatic hypotension. So while we managing cases, we have to increase the L-DOPA by very slowly and with a slow titration. Medical treatment include alpha agonist, doxydopa, pyridostigmine, and ampreloxetine, which is a norepinephrine reuptake inhibitor. Management of supine hypertension also includes some instructions like elevated head of the bed to avoid supine posture, sweet snacks at bedtime, heating of the bed over the abdomen and the pelvis, and the medications like nitroglycerin, nifedipine, and sildenafil. Thermoregulation also is one of the dysautonomia due to Parkinson's disease. It is present in 30 to 50% of Parkinson's disease patients, which have experienced paroxysmal attacks of hypothermia as well as sweating attacks in the face and the upper body, usually nocturnal, and in the advanced cases usually coincide with the off state or akinesia state. Thermoregulatory dysfunctions are mainly central due to extension of synchronopathy to the heat regulating center in the hypothalamus, while the respiratory or pseudomotor dysfunctions are peripheral due to alpha-synuclein pathology of the postganglionic sympathetic cholinergic fibers to the sweat glands. This is an interesting topic where the A is the normal thermogram of healthy control subjects, while in the right side there are two cases of Parkinson's disease where there is a thermoregulatory deficit, and we can notice the thermoregulation in these patients is asymmetrical, which means that the asymmetrical criteria of Parkinson's disease may extend from the motor manifestations to the non-motor manifestations. Management of thermoregulatory dysfunction is usually difficult, but there is some things we can take. If hyperhidrosis occurs during the off period or the dyskinesia, we can adjust the L-DOPA and dopaminergic drug dosing to avoid this hyperhidrosis. Deep brain stimulation also has a benefits for prevention of severe motor fluctuation as well as thermoregulatory dysfunctions. Anticholinergic drugs like glycobiolate may be beneficial, and if the pseudomotor dysfunction is focal, we can use botulinum toxin injection. Another thing in thermoregulation of Parkinson's disease is the Parkinsonism hyperpyrexia syndrome, which is a rare potentially fatal thermoregulatory problem like the neuroleptic malignant syndrome, and occur due to rapid cessation of anti-Parkinsonian dopaminergic medication. And this scenario can be confronted after the application of the deep brain stimulation. After that, we have to withdraw the dose of L-dopa very slowly to avoid such life-threatening condition. The upper GIT and Parkinson's disease, the drooling is one of the major problems in Parkinson's disease patients. It may be affected from 10 to 70% of patients. It is one of the motor-non-motor overlap phenomena, but we have to notice that salivary secretion in Parkinson's disease, the amount is unchanged or even smaller than that of the normal individual. But cyanoria or drooling is mainly due to some things rather than salivary secretion amount, which includes the decreased rate of spontaneous swallowing due to pharyngeal bradykinesia, pharyngeal somatosensory deficit with little reaction salivary stimulation, impaired dual task performance, where Parkinson's disease patients usually experience drooling while they are doing some mental acts, and sometimes gravitational in advanced Parkinson's disease patients due to excessive leaning and forward flexion of the head. Management of drooling is dependent on its severity, where mild cases can be managed by chewing gum, which activates the automatic swallowing reflex, or sometimes we can use anticholinergic drugs like atropine drops, glycobiolate, or scopolamine patch. Botulinum toxins is very effective in such problem. Can be injected in the parotid and occasionally can be injected in the submandibular salivary glands. Dysphagia is also another problem in Parkinson's disease, which represent one of the motor-non-motor overlap corners, which occur due to impairment in the dopaminergic substantia nigra neurons, as well as non-dopaminergic brainstem swallowing central pattern generators. Dysphagia is one of the very important risks of hospitalization. It may result in repeated aspiration pneumonia, difficult intake of orally administered medication, unintentional weight loss, or even premature mortality from the repeated aspiration pneumonia. Dysphagia in Parkinson's disease affects the four phases of swallowing, the pre-oral, the oral, and etc. But the main brand is present in the pharyngeal phase due to bradykinesia, constriction dysfunction, and the delayed airway closure with microaspiration. Also, the esophageal phase due to hypomotility of the esophagus with multiple contraction due to dysynergia of the esophageal movement. This kind of dysphagia in other atypical Parkinson's disease have different pattern, where in multiple system atrophy and BSCB, it usually occur very early within the first 5 years of motor manifestations, which the presence of early dysphagia, it gives a red flag against the diagnosis of typical Parkinson's disease. In BSCB, the dysphagia is mainly oral and pharyngeal. In multiple system atrophy, it is mainly esophageal. So it has a different pattern rather than typical Parkinson's disease. Management of swallowing dysfunction is also a very difficult issue. Sometimes logopedic training and visual biofeedback with visual assisted swallowing therapy is beneficial for some cases. Adjustment of the head and the body posture, as well as adjustment of the dietary strategy with texture modification. Sometimes pharmaceutical therapy like botulinum toxin can be effective. Novel technologies such as neuromuscular electric stimulation and deep brain stimulation, repetitive transcranial magnetic stimulation may give some beneficial results. And lastly, the dopamine therapy has a controversial effect. Some cases have improvement of the swallowing, other cases may deteriorate the dysphagia due to administration of L-dopa. Regarding to the gastroparesis, Parkinson's disease patients experience marked prolongation of the gastric emptying time due to decreased amplitude of peristalsis. Gastroparesis management, L-DOPA usually exacerbate gastroparesis. Domperidone is good and have a little effect, a central effect due to non-crossing of the blood-brain barrier, but it is dangerous due to its arrhythmogenic effect. Endoscopic pyloric botulinum neurotoxin injection may be beneficial in some cases. Deep brain stimulation also may improve gastric imaging in Parkinson's disease patients. Let's go to the gut-brain axis. First, all of us, we know the double hit theory, which assume that alpha-synuclein accumulation start in the olfactory bulb or the enteric nervous plexus of the colon. Regarding to the small intestine, functional imaging and the wire motility capsule revealed that 25 to 50% of Parkinson's disease patients have impaired small bowel motility transit time. Also, these patients have increase in small intestinal bacterial overgrowth. And this is a very important thing because all of us, we know absorption of L-DOPA occur in the jejunum, not from the stomach, and impaired intestinal motility may one of the association of a cause of severe motor fluctuation. This is a Donbezil PET scan, and we can notice that in Parkinson's disease patients, there is decreased signal in the small intestine, which start very early, which denotes that parasympathetic denervation of the intestine may start in the prodromal premotor phase of Parkinson's disease, even if it is not clinically symptomatic. Constipation is one of the very important things. It is the earliest, most common, and the most disabling GIT symptom of Parkinson's disease. It is present from 30 to 90% of patients, and this discrepancy is related to a change in the definition of constipation. However, Lewy body accumulation in the enteric plexus start rostrally and progress caudally, and start from the outer mesenteric layer and progress to the inner mucosal layer. This makes that constipation have different mechanisms regarding to the Parkinson's disease stage. In premotor and the early phase, it is a slow transit constipation due to prolongation of the intestinal passage of stool. In advanced cases of Parkinson's disease, constipation have a different thing, which is due to outlet constipation as a result of anorectal dyssynergy. And this will be reflected according to the management of constipation. This is a radio-opaque marker. In the left, the person takes 60 radio-opaque marker, and after 7 days, this X-ray occur. We have noticed in the left side, it is a normal person, only 4 markers are present. In the B, which is the middle, it is a case of early Parkinson's disease. We can notice that there is a 28 marker and distributed in the whole colon. In the right side, we can notice that the markers are nearly retained. 57 markers are retained, and all of them are present mainly in the sigmoid and the rectal, which means that advanced Parkinson's disease patients have outlet constipation. Regarding the difficography, patients with Parkinson's disease show a dilated rectal size, pelvic floor dyssynergia, acute anorectal angle, which must be straightened during the defecation, and the increased post-defecation residual volume. This is a 3D colonic volume. The right side is a Parkinson's disease patient. We can notice a huge dilatation of the colon, and this dilatation is predominant in the sigmoid and in the rectum. One of the very important investigation is the ultrasound for the vagus nerve, where patients with GIT symptoms show diminished diameter of the left and right vagus nerve in ultrasound duplex study, and it has a 75 to 80% sensitivity and specificity. Management of constipation is dependent on the stage of Parkinson's disease, and it is a very important thing because management of constipation is associated with parallel improvement of the motor function and the reduction of the motor fluctuations. There is multiple strategies related to the management, including the bulk agents, the osmotic laxatives, some drugs which increase the secretion of the intestine and have a secondary improvement of the intestinal motility. The probiotic and the prebiotic fibers are also beneficial. Regarding to the dyssynergic defecation, it usually occurs during the off period and usually responded to dopaminergic therapy. So if a patient with advanced Parkinson's disease have a dyssynergic defecation, we can advise him to pass stool during the on phase and take a soluble levodopa and rapidly acting drugs before the act of defecation. Squatting position is very important in such cases because it results in relaxation of the puborectalis and make easier defecation. Botulinum toxin can be injected to the puborectalis muscles and as well as the external anal sphincters. Neurostimulation like sacral nerve stimulation may be beneficial. Biofeedback is also beneficial in such cases. The GIT manifestations are usually associated with the motor fluctuation because the GIT, the delayed gastric and hectic gastric motility, the presence of H. pylori also may consume the L-DOPA as it consumes it for its growth. The hectic gastric motility may result in delayed DOPA absorption as well as accumulation of doses and hence the fluctuation. The gastric motility abnormality is usually due to suppression of the cologastric reflex by the constipation. So treatment of constipation may improve the gastric motility. Constipation in multiple system atrophy start from the beginning due to anorectal dyskinesia. I have no transit constipation like typical Parkinson's disease. Regarding to the urogenital system, there is a dynamic relationship between the lower bowel and urinary tract dysfunction. Urinary symptoms are reported from 27 to 85% of Parkinson's disease, and they have multiple mechanisms which may be central, and the central pattern result in storage dysfunction and overactive bladder. Degeneration of the sympathetic and the parasympathetic supply to the urinary bladder may result in stream and voiding dysfunction. However, we have to know that urinary retention is rare in Parkinson's disease. It is usually give us raise the possibility of multiple system atrophy. And when urinary dysfunction is present, usually occur late, several years after the onset of motor manifestations. Treatment of the urinary bladder depends on the symptom. If it is overactive bladder, we can use antimuscarinic drugs. Behavioral therapy like bladder training, biofeedback is also beneficial. Neuromodulation like percutaneous tibial nerve stimulation, sacral nerve stimulation, and deep brain stimulation also improves the urinary dysfunction. The detrauteral muscle hyperactivity can be also managed by botulinum toxin, which can be injected in the bladder through a flexible or rigid cystoscope. Regarding to the sexual dysfunction, it is one of the most neglected non-motor manifestations. It has a high Parkinson's disease patient have a decreased libido, orgasmic dysfunction, and erectile dysfunction. Also, there is some indirect causes which reduce the sexual relationship, including the drooling, the seborrhea, REM behavior disorder, hypomimia, depression. Another thing is that dopaminergic therapy may result in hypersexuality, which is a dopamine dysregulation syndrome and unacceptable behavior towards the sexual gratification. Management of sexual dysfunction, erectile dysfunction can be managed by subcutaneous or sublingual apomorphine, phosphodiesterase 5 inhibitors like sildenafil, tadalafil, and vardenafil. But these drugs, we have to be cautious as they increase the orthostatic hypotension. Libido can be improved by topical testosterone, intracavernous babaverine or prostaglandin may improve also. And the dopamine-related hypersexuality is sometimes very difficult and needs adjustment of the dose of L-DOPA with atypical antipsychotics. At the end of my presentation, the non-motor manifestations, including the dysautonomia, have a spectrum in the onset. Constipation may start pre-motor 20 years before the clinical manifestations. However, urinary symptoms and also static hypotension and dysphagia may occur very late in Parkinson's disease patients. The retrospective identification of non-motor manifestation after the appearance of motor manifestation usually reduce its clinical importance and keep it in the corner of diagnostic confirmation. However, this autonomic manifestation can be held as a biomarkers for Parkinson's disease patients, but these biomarkers need more studies to increase their sensitivity and specificity, as well as the use of objective measures for their assessment. My home message is dysautonomia is a common yet underestimated manifestation of Parkinson's disease, despite its great deleterious effect on patients' dependence, activity of daily living, or quality of life. Autonomic nervous system function should be routinely assessed in every patient with provisional diagnosis of Parkinson's disease. Few Parkinson's disease patients, especially familial type, have little non-motor and dysautonomic profile. Don't forget the effect of anti-Parkinsonian medication while you are treating dysautonomia. Sometimes these things may increase the orthostatic hypotension, the gastroparesis, etc. My final message is that autonomic nervous system disorder represents the black box and the backyard of neurology, which is a vacant area of research, and more attention is needed in this field. This is my used references, and thank you for your attention and attendance, and have a good night. Thank you.
Thank you, Dr. Rafi, for this fruitful lecture and comprehensive. And I think we will postpone questions after the third session. Please, for any questions, you could just write your questions in Q&A box. So we will discuss after the third session. This is I would like also to thank Professor Tamawi, Professor Magid, Professor Hatem for this good initiative of Movement Disorder Society, Movement Disorder chapter. It's my honor to be part of this chapter, and I'm happy with this great program. And I would like to thank, it's my pleasure also to co-chair this session with Dr. Hanan Ahmed, Dr. 𝐤𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬 today, Dr. Rafi and Dr. Anwar and Professor Jawad. And the time now is for the second session, and it's my pleasure to introduce Professor Muhammad Anwar, Associate Professor of Neurology, Asyut University. Professor Muhammad Anwar, one of the active members in movement disorder chapter of Egyptian Society and interested in movement disorders. And he will talk today about an important subject, which is pharmacological treatments of Parkinson's disease. Professor Muhammad, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank Professor Dr. Majid Abdel Nasir, the head of the Egyptian Society of Neurology and the Neurosurgery, and the Professor Muhammad Tamawi, the head of chapter movement chapter, and the Professor Hatim, the secretary, Professor of Neurology and Secretary of Movement Disorder chapter. I'd like to thank Dr. Ali Shalash for his beautiful presentation for me, and I'd like to thank Professor Hanan Amir, Professor Wafiq for his concise and delicious presentation about dysautonomia, which is a very difficult presentation and very difficult and ugly presentation for Parkinson's disease patient. And I would talk about the pharmacological treatment of Parkinson's disease, which is a challenge beginning by levodopa or not sparing levodopa for later presentation, or from the beginning, or the use of multiple drugs like dopamine agonist now inhibitors. And also there is a debate. There is no yet till now a disease-modifying therapy for this disease. First of all, I'll talk about the general historical background of Parkinson's disease and the diagnosis of Parkinson, principles of pharmacological treatment when initiating pharmacological therapy, pharmacological management of Parkinson's disease, pharmacological therapy in early Parkinson's disease and advanced non-motor manifestation of Parkinson's disease. History of Parkinson. The first described by the English physician James Parkinson at 1870, where he talk about the check policy and describes the symptomatology of the disease. Coined the name Parkinson's disease by Jane Martin Charcot at 1862. The first drug to be prescribed is L-Dopa, was introduced at 1968. The first gene to be discovered at 1997. First is the AAN, the American Academy of Neurology, National Institute for Health and Clinical Excellence, Unified Parkinson's Disease Rating Scale, United Kingdom Parkinson's Disease Society, Brain Bank, and Clinical Diagnostic Criteria. We will discuss all of these in our topics. Parkinson's disease is the second commonest neurodegenerative disease, exceeded only by Alzheimer's disease. It's estimated approximately more than 6 million persons in the world suffer from Parkinson. Annual incidence is about 0.2 for 1,000, with prevalence of 1.5 for 1,000. The mean age of onset is about 60 years, but cases decrease in patient may be seen in patient less than 20 years. But the main pathological features is the destruction or loss of neurons in the dopaminergic nigrostriatal pathway, with dopaminergic neurons in the substantia nigra that normally inhibit the output of GABAergic cells in the striatum are lost. 80% of the dopamine producing cells lost before the onset of the symptoms to start. Emerging pathogenic mechanisms of Parkinson's disease is the appearance of theories for alpha-synuclein misfolding and aggregation, mitochondrial dysfunction, dysfunctional protein clearance system, ubiquitin proteasome system, autophagy, lysosomal system destruction, severe endoplasmic reticulum stress, motor circuitry pathophysiological changes, and neuroinflammation. The appearance of the symptomatology occur before the occurrence of the neuronal cell death of the dopaminergic neuron occur before the occurrence of the symptomatology by many years, may reach to 1 or 2 years, and so to sometimes some symptoms may reach to 10 years before the neuronal cell loss. This subtle non-motor manifestation, like autonomic dysfunction, first clinical symptoms appear after destruction of more than 70% of neurons. Neuronal cell loss continue to loss, and the symptoms continue to appear, and the complication of drugs and the motor complication of the disease more to appear. With increasing the years of the disease, there is severe presynaptic and postsynaptic loss and decreasing in the response to levodopa. The main clinical features of the Parkinson's disease, according to the United Kingdom Parkinson's Disease Society Brain Bank, there is some premotor symptoms like constipation, anosmia, rapid eye movement, sleep behaviors, or depression and the cognitive disturbance. The main 4 cardinal symptoms, resting tremors, muscle rigidity, bradykinesia, postural instability. Always signs start in one limb, and usually an upper limb, an arm, and spread to the other limb on the same side. Clinical features of non-motor manifestation, also of motor manifestation, like micrographia, masked faces, reduced eye blinking, soft voice, dysphagia, and gait disturbances. Non-motor features like anosmia, sensory disturbance, mood disorders, sleep disturbance, autonomic dysfunction, and the cognitive impairment also may occur. According to the diagnostic criteria of United Kingdom of Parkinson's disease, bradykinesia and at least one of the following. The presence of bradykinesia and at least one of the following to diagnose of one of the sure diagnosis of Parkinson's disease is the muscular rigidity, resting tremors, or postural instability. For exclusion criteria for Parkinson, if there is a history of stroke or repeated head injury or antipsychotic dopamine depleting drugs, history of drug intake, definite encephalitis, or more than one affected relatives of his family, sustained remissions. Also, if there is strictly unilateral features after 3 years, or there is supranuclear gaze palsy, cerebellar signs, early severe autonomic manifestation not with Parkinson's disease, early severe dementia is not with the diagnosis, if there is language disturbance or memory, presence of cerebral tumors, or Babinski positive sign, this may of the exclusion criteria of Parkinson's disease. The supportive criteria for diagnosis of Parkinson is the unilateral onset, excellent response to levodopa, resting tremor present, severe levodopa-induced chorea, progressive disorders, levodopa response for over 5 years, persistent asymmetry affecting the site onset, clinical course over 10 years. General consideration regarding pharmacological treatment of Parkinson. The diagnosis of Parkinsonism, Parkinson's disease should be secure. First of all is secure the diagnosis of Parkinson's disease. Therapy in Parkinson's disease is patient-centered in order to maximize quality of life and minimize disability. Drug selection should be individualized depending on the characteristics and the need of the patient, comorbidity, comorbid motor symptoms, intercurrent medical illnesses, and the medications used. An initiation or change of the drugs must be discussed with the patient or relative. The ultimate aim of treatment to improve quality of life and do not affect long-lasting progression of the disease. The mainstay aiming to correct dopamine insufficiency, tailoring to individual needs. The current text is symptomatic relief without effect on slowing disease progression. On progressive disease, long-term treatment requiring follow-up, dose adjustment, and drug manipulation. Drug choices depend on evidence of efficacy, side effects, cost, and individual needs. Initiating pharmacological therapy, when to start treatment. Treatment should be started when non-motor symptoms begin to cause physical or social disability and impair quality of life. Tailoring to disease severity at presentation. Discuss drug treatment options with the patient and the family. Allow adequate time interval to assess drug responsiveness. Dose escalation and reasonable dose with less side effects. Consider cost, consider the availability and the access to drugs. What's pharmacological treatment? The items of pharmacological treatment, drugs mainly used in Parkinson's disease, acting on dopaminergic system or acting on cholinergic system, or drugs acting on disease modifying, which is not up till now over hope for the patient and the treating physician. The mechanism and site of action of these drugs, mainly the anti-Parkinsonian drugs. If we see this figure, we will find that the mechanism of action of dopamine, L-DOPA, is transmitted to dopamine, the DOPA decarboxylase, which is postsynaptic act on dopamine D1, D2, and D3, and reuptake by COMT and MAO-P inhibitors for degradation of dopamine. The mechanism of action of 5 items, of 5 drugs, of groups of anti-Parkinson treatment is illustrated in this figure. As we find that L-DOPA act in presynaptic to change to dopamine, which act postsynaptically on D1 and D2. The second group is the dopamine agonist groups, Biribidil and pramipixole, Robirinol, and apomorphine, rotigotine, which act on dopamine receptors, mainly D2 and D3. Bromocriptine and bergolide, dopamine agonist acting on D1 and D2. COMT inhibitor like entacapone and tolcapone, they increase the dopamine level in the synaptic by prevent degradation of dopamine by COMT. MAO-B inhibitors as razagiline, selegiline, safenamide, they act on monoamine oxidase B inhibitor to prevent degradation and increase in the dopamine level in the synaptic. Also amantadine, which act by enhancing the dopamine activity by blocking NAMDA antagonist. Is the most effective medication to improve motor features, bradykinesia, and rigidity in Parkinson's disease. Have fixed dose combination with carbidopa, available in the market in carbidopa 1-4 or 1-10. Immediate release or controlled release. Levodopa, the strategy is to start very low dose, escalate to tolerate the dose. Starting slow reduces nausea and increases compliance. Half tablet daily, increasing weekly by half tablet to initialize to reaching the target 100/25 every 8 hours or 6 hours. Common side effects occur the motor complication and the GIT manifestation. As we show in this figure, we saw the effect of L-dopa at the first 3 years, where is the honeymoon period of L-dopa in Parkinson's disease patient. The clinical response is full and of improving the quality of life of the patient and improving the motor symptoms. The plasma level in pulsatile manner, but in high efficacy. This lead to disappearance of complication and no complication till the 4 years. After 4 to 6 years, end of dose dyskinesia appear. This end of dose akinesia on off phenomenon. After 6 years, we saw there is no definite on dyskinesia will appear. During the on phase, there is marked end of dose dyskinesia, and the on dyskinesia appear. This and the clinical response for dopa use in Parkinson's disease patient will decrease. Dopamine agonists like ergot derivative, bromocriptine, bergolide, or non-ergot apomorphine, biribidil, or pramipixole, or riniprol, or rotigotine, all are oral except apomorphine, subcutaneous, and the rotigotine is transdermal patch. The dopamine agonist drugs and the mechanism of action, and they can be used as monotherapy. All of us know that, and they know the mechanism of action. And so I'll pass over. Monoamine oxidase inhibitors like selegiline, razagiline, or catecholamine transferase inhibitors, entacapone and tolcapone. Dopamine facilitator like amantadine act as antiviral agents. Several pharmacological actions may alter the dopamine release in the striatum and has anticholinergic properties. Block NAMDA glutamate receptors used as initial therapy for mild Parkinson's disease may be helpful in dose-related fluctuation and dyskinesia for L-dopa. The pharmacological treatment of early Parkinson's disease. Early Parkinson's disease, early disease refers to Parkinson's disease in people who have developed functional disability and require symptomatic therapy. Treatment of Parkinson's disease consists of a dopamine replacement strategy to improve disease symptoms. There is no known benefit of withholding treatment from patients who have disease symptoms. So many factors that influence this decision include to start early L-dopa in the patient, I must consider the patient's age, employment status, participation in activities such as hobbies, and other quality of life issues. The symptom severity of the patient, whether the symptoms affect dominant hand or not, the cost of the drugs, the patient preference, and the comorbid conditions like diseases like cardiac diseases, BPH, glaucoma. Pharmacological therapy in early Parkinson's disease, the goal of the initiation to reducing motor symptoms, improving quality of life without causing side effects. Monotherapy with dopamine agonist or levodopa or MAO inhibitors. Anticholinergic may be used in tremor predominant manifestation. Adjust dopamine agonist or L-dopa dose to improve response. American guideline and the NICE guidelines remains levodopa the most effective medication for the treatment of motor symptoms. Levodopa used as a symptomatic treatment for people with early Parkinson's disease. The dose of levodopa should be kept as low as possible to maintain good function and reduce the development of motor complications. Dopamine agonists are the second most potent class of medication. Dopamine agonists less likelihood for producing fluctuation, but they are less effective, higher side effects, and more expensive than levodopa. Dopamine agonists may be used as a symptomatic treatment for people with early Parkinson's disease. A dopamine agonist should be titrated to clinically efficacious dose. If side effects prevent this, another agonist or drug, another class should be used in its place. MAO-B inhibitor may be used as a symptomatic treatment for people with early Parkinson's disease. Amantadine can be used as a treatment for people with early Parkinson, but shouldn't be a drug of first choice. Anticholinergic may be used as a symptomatic treatment, typically in young people with early Parkinson and severe tremor. Shouldn't be of first choice due to limited efficacy and the propensity to cause neuropsychiatric side effects. Beta-adrenergic antagonist may be used as a symptomatic treatment of selected people with postural tremor in Parkinson's disease. Drug selection in the American Academy of Neurology and the NICE guidelines, if symptoms are very mild and the patient may be chosen to begin, not to begin therapy. If the symptoms are very mild and do not affect the quality of life of the patient, choose no therapy. Over levodopa to people with early stage of Parkinsonism with when they impact on their quality of life. If there is no impact on their quality of life, consider dopamine agonist and the MAO-B inhibitors. In the Australia, levodopa and the dopamine agonist and the monoamine oxidase and the catecholamine methyltransferase inhibitors used as an initial therapy for early Parkinson's disease, and they show level of evidence of level A. The pharmacological therapy in early Parkinson prefer to begin with levodopa or dopamine agonist or MAO-B. And we show this is the first choice for treating an early Parkinson's disease is the use of levodopa or dopamine or MAO-B. Levodopa show symptom control very efficacious and high efficacy in controlling motor symptoms, but have or had motor complication. Other adverse events appear. In dopamine agonists, the efficacy is less than the levodopa with less motor complication, but also have another side effects for dopamine agonist. MAO-B is less efficacious, of less efficacy in treating motor symptoms, but can be used in first choice option for treating early Parkinsonism. The anticholinergic and beta blocker and the amantadine, no evidence for use in early Parkinson, except in some situation like the presence of tremors may be used anticholinergic and beta blockers, or mild symptoms may be used amantadine. This schedule shows the early Parkinson's disease management. First of all is the diagnosis of idiopathic Parkinson's disease. 4 slight symptoms. The DataTop study shows that MAO-B inhibitor may have a disease-modifying therapy, may have. So may be used in if there is mild symptoms and no treatment and no functional disability. If there is a functional disability, we begin by this functional disability. Mainly, if there is a tremor, we can begin by anticholinergic drugs. If there is tremors and/or bradykinesia, we can use one of 2 dopamine agonists if the patient is less than 70 years, or L-dopa if the age of the patient more than 70 years. The pharmacological treatment of later Parkinson's disease. Later disease, Parkinson refer to Parkinson in people who levodopa please, sorry. Later disease refer to Parkinson in people who levodopa have developed motor complication and the progression of the disease. No single drug can be drug of choice for treatment of later Parkinson's disease, but we can use adjuvant therapy like dopamine agonist or 𝐶𝐬𝐬 inhibitor or MAO-B inhibitor. Over a choice of dopamine agonist, MAO-B inhibitors or 𝐶𝐬𝐬 inhibitors as adjuncts to levodopa for people with Parkinson's disease who have developed dyskinesia or motor fluctuation despite optimal therapy of levodopa. If dyskinesia is not adequately managed by these modifying drugs, we consider amantadine. If there is response is less, we consider anticholinergic to people with Parkinsonian tremors. If there is motor fluctuation to levodopa, risk factors for appearance of this levodopa motor fluctuation is the young age, increased severity, long Parkinson's disease duration, high levodopa dose. Clinical patterns wearing off, delayed off or delayed on, random on off, no on. This occurred due to fluctuating plasma level of L-dopa, intermittent delivery of L-dopa to the brain, pulsatile striatal dopamine stimulation, disease progression, impaired or erratic absorption of L-dopa. And the motor fluctuation occurs. So the management of motor fluctuations, we can do fragmentation of the dose up to 6 to 7 times per day, or the substitution of regular with controlled release L-dopa, or we can add 𝐶𝐬𝐬 inhibitors like entacapone or tolcapone to reduce the metabolism of levodopa, extending its plasma half-life. MAO inhibitors like selegiline or razagiline, add dopamine agonist or safenamide. Levodopa dyskinesia. This dyskinesia differs from types of levodopa induced, maybe occur at the peak, so-called peak dose dyskinesia, or biphasic dyskinesia. What? Or wearing off dyskinesia. Treatment of this dyskinesia, dyskinesia occur at the end stage of the patient. The management of this dyskinesia, lowering the dose of L-dopa, use amantadine or clozapine, particularly useful when hallucinations are also present, high frequency subthalamic deep brain stimulation. Conclusion, which medication reduce off time? Entacapone razagiline may be used to decrease the off phenomena. Pergolide and pramixol, robenrol and tolcapone should consider to reduce off time. Sustained release carbidopa, levodopa. Which medication reduce dyskinesia? Amantadine may be used to reduce dyskinesia. Insufficient evidence support the efficacy of clozapine, but can be used. Advanced Parkinsonism, with the advanced occurrence of the motor and the autonomic and the cognitive behavioral more complication for L-DOPA or dopamine agonist. This lead to the appearance of advanced Parkinson's disease. Fragmentation of the dose, substitution of regular with controlled released L-DOPA, COMT inhibitor may be used, MAO inhibitor may be used, continuous infusion of L-DOPA carbidopa like duodopa, liquid effervescent levodopa like methyl ester levodopa, treatment of motor complication like dyskinesia and fluctuations, treatment of non-motor manifestation. If no definite response, consider DBS. Carbidopa levodopa infusion, duodopa, the morning bolus dose is usually 5 to 10 milli. The continuous maintenance dose is 2 to 6 milli per hour. It is intended for people with more advanced disease whose symptoms are no longer respond well to oral carbidopa levodopa. Instead of taking a pill, people with Parkinson's disease can receive carbidopa levodopa in a gel form through an infusion pump. This infusion pump is surgically placed tube to the jejunum. This is the device, and this tube is introduced on intestine to be in the intestinal pooling. If we have already an advanced Parkinson's disease, and we have a combination therapy agonist and dopamine agonist and levodopa, if there is motor fluctuation, add COMT inhibitor. If still dyskinesia, we can add amantadine. If uncontrollable motor complication, we use DBS. If there is insufficient treatment and insufficient and drug resistant to tremors, we can use from the start DBS. Pharmacological treatment of non-motor manifestation. Cognitive dysfunction appear in about 80% of Parkinson's disease. Dementia in approximately 30% of patients. We can use donepezil or rivastigmine. Consider memantine for people with Parkinson's disease dementia only if cholinesterase inhibitors are not tailored or rare contraindicated. Depression occur in about 40% of patients. We use SSRIs or tricyclic antidepressant, but take care may increase the autonomic dysfunction in patients with advanced Parkinsonism. Pramipixole may have antidepressant effect above the anti-Parkinsonian effect. ACT in severe cases and refractory cases. Psychotic symptoms, quetiapine and clozapine may be used. Other atypical and typical antipsychotic agents may be harmful due to worsening of the motor function. Consider ACT in severe and refractory cases. REM sleep behavior disorders, melatonin and clonazepam may be used. Sleep disorder breathing management, you must diagnose the patient firstly by consider sleep work. Study confirms the presence, the use of CPAP treatment that can improve the condition. Modafinil may be used in for daytime hypersomnolence in people with Parkinson's disease. Methylphenidate may be used for fatigue. Nocturnal akinesia, consider levodopa oral dopamine agonist may be used to treat nocturnal akinesia. Consider rotigotine if levodopa and oral dopamine agonists are not effective in treating nocturnal akinesia. Anxiety.
دكتور انور معلش التايم احنا
Yes, I'll end. Yes. Also static hypotension, Dr. Wafi said here, initiation of pharmacological therapy in Parkinson's disease, when and why and how. Early initiation of dopaminergic therapy doesn't prevent disease-modifying effect, but does reduce disability. Evidence supports the use of levodopa as initial and symptomatic treatment in most patients with Parkinson's disease, starting with low dose, titrating to therapeutic threshold. Monoamine oxidase beta inhibitor and dopamine agonist can be reserved as a potential adjunct treatment later in the disease course. This study confirms the early use of levodopa. The end. The early use of levodopa begin by levodopa early in the disease, bring us a full response on a state of no fluctuation for about 4 years, 2 to 3 years. After that, the onset of motor fluctuation will appear, and the levodopa dose akinesia or on dyskinesia appear earlier in the progression of the disease. If we use sparing levodopa for later stage to be used late, we begin by dopamine agonist, but this will not give us a good response from the start, but they delay the activity of the patient and will give the patient less activity and less life expectancy. So early levodopa use may give you a good quality of life, a good motor symptom response, but will lead to more appearance of the side effects very early, and the motor fluctuation and the dyskinesia will appear early in the disease. The neuroprotective agents that alter the pathogenesis, the hope in the biogenic antioxidant or the presence of disease-modifying therapy. Vitamin E is a neuroprotective therapy for people with Parkinson. Coenzyme Q10 dopamine agonist monoamine oxidase inhibitor used as a neuroprotective for people with Parkinson. This need clinical trials. Thank you.
Now all attendees are encouraged to put their questions on the question and answer bar. We have many questions actually for the three speakers. Dr. Tamawi, you can start if you want.
Of course, welcome Jawad, and I'm very happy to have you on a webinar. Not physically this time, but welcome. You are always welcome, either by yourself or on webinar, and we are always happy to have you with us. So you are always welcome. And I'd like to thank Andalus for sponsoring this webinar, and also Masr 2000 for preparing the meeting. Okay, may I start by a small question to Jawad. I have a problem with anosmia in Parkinson's disease. Do you have any solution for this?
Oh no, that's an excellent question, but no, there is no easy fix for anosmia. It's a sense, it's lost, and there's really, you can't do anything to recover it. I am not sure if there's any drug or any alternative therapy that could be applied to anosmia. It's something people just have to get used to living with it if they really have troubling one.
Thank you. I would also like to thank Dr. Bahanasi and Dr. Anwar for their great contribution. And I now leave the microphone to Dr. Hatem and Dr. Hanan for the question and answers. Okay.
Okay, we'll have some questions for Dr. Wafi, the first speaker. The first question is about the underlying causes of Parkinson's disease. It's a general question rather than a specific one related to your clinical scenario of non-motor manifestation of Parkinson. However, do you have any briefing for the underlying causes of Parkinson's disease for the attendance, taking into consideration that we are an educational webinar for audience?
If I take this regarding to my topic, there is a double hit theory where Parkinson's disease is the interaction between external factors like wine, like organophosphorus compounds or toxins, which may be dealt with microbiota in the GIT, resulting in alpha-synuclein phosphorylation. There is multiple theories about alpha-synuclein propagation to the CNS through the vagus nerve, which may be the presentation why constipation may be one of the initial manifestations of Parkinson's disease. Another route of progression is the olfactory bulb, where progression of alpha-synuclein occur to the temporal lobe, and this may be also the presentation why REM behavior disorders or sleep disturbances may prolong the clinical motor manifestations of Parkinson's disease. It is a multifactorial disease, and I think this is what is related to my topic today.
Yes, it's I mean it's an interaction between environmental and genetic causes that will start the disease in the brain stem and then to the temporal lobe and then
propagate according to the Barak stages in the 6 stages of Barak to the temporal lobe, to the frontal, and resulting in various motor and non-motor manifestations.
Okay. Another question about recording of your lecture. Just to say that all presentations are recorded and they will be put in the YouTube channel after permission of Dr. Maged Abdelnasir and Dr. Mohammed Tamawi. A question for Dr. Anwar. Are you here, Dr. Anwar?
Yes, with you.
Yes. First, I have a question about the starting levodopa.
There is, Dr. Hatim, there is a debate as to start with levodopa early or late. The last study conducted in Netherlands last years from 2019 to 2100 to about 2016. This controlled trial, the randomized trial for the beginning of levodopa or sparing levodopa for the late stage after 40 weeks of starting the study, shows that most of the patients age about 65 plus minus 8 years. So the beginning of treatment with levodopa or later on dopamine agonist must be around 70. This may be due to the study designs before. But in my opinion, tailoring the drugs for the patient and symptomatology of the patient. If the patient is about 50 years and he is annoying about the motor symptoms, start very low and very slow with low dose and follow up the patient for complications. But the studies occur around the age of 65. So, our illustration shows that dopamine agonist may be started before the age of 70 and spare the levodopa to after 70. This may be related to the methodology of the studies done before. But in our work, in our clinical experience, for most of our professors and most of this pharmacological treatment and strategies, the symptomatology and the quality of life is the target to improve the quality of the life of the patient. If the patient is below the age of 50, I'll start levodopa, but with very low dose and increase the dose gradually.
Okay, it should be
Dr. Hatim, if you allow me, just to have a comment and a question for Dr. Anwar.
Yes.
Dr. Mohammed, you have mentioned that for cognitive deficit in Parkinson patients, the American guidelines put the donepezil as a first choice. However, the drug which has been approved for Parkinson dementia complex is the rivastigmine. I don't know how to comment on this. Another thing about the age of starting L-DOPA for Parkinsonian patients, I think 70 years is a little bit high. Maybe for the Western countries, because the life expectancy is higher than our region, I think it's, for us, it's maybe 60 or rather than 70 years. Thank you very much for your presentation.
Thank you. Thank you. Thank you, Dr. Majid. Dr. Majid, you asked about the cognitive dysfunction in Parkinson patient. Yes, American Academy of Neurology and the NICE recommends the use of rivastigmine and the donepezil, but they put donepezil the first choice. This recorded about the studies done before, because the donepezil and the rivastigmine don't increase the cognitive neuropsychiatric manifestation that may be aggravated with memantine, which is largely used today for cognitive deterioration as dementia. But memantine lead to neuropsychiatric manifestation and they may aggravate the condition of Parkinson patient. Studies done about the use of rivastigmine and the donepezil and recommend level B for the cognitive disturbance or dementia in Parkinson patient. I'm with you. Yes.
Dr. Hatem, can I say something? Comment something?
Yes. Yes.
Yeah, I agree with Dr. Anwar, but to my knowledge, that rivastigmine, I think it is the best, and this is most evidence-based, used in Parkinson's disease and of course in Lewy body. Then donepezil, and of course, as he said, memantine. So the evidence base and recommendation is mainly for rivastigmine, followed by donepezil and memantine. We have negative results about its use in Parkinson's disease. And also rivastigmine, we have another data about improvement of attention, of cognition, mood, and also gait in patients with Parkinson's disease. It could not help. It is not approved for gait, but it could be have another actions on this important phenomena. Thank you.
Okay, question for Dr. Bajwa. Are you here, Dr. Bajwa?
Yes, I'm here, I'm listening.
You have many questions to answer.
I'm
the
here.
first one is, how long is DBS expected to remain effective?
So, the simple way to look at that is that your motor symptoms generally continue to improve or respond to DBS for a long time. We now have data for patients exceeding 10 to 15 years, almost life expectancy after DBS. So the impact on motor symptoms continues to be sustained. You may need to adjust DBS as you do with your medications. But what seems to be the practical problem that we all encounter is that the non-motor part of the disease catches on. So a simple example of some years ago, it was an orthopedic surgeon, this is in US, and he did very well with DBS for almost 4 or 5 years. And one day he comes to my clinic and he doesn't know why he's there. So that's the challenge. So the motor symptoms continue to improve, but the non-motor symptoms then continue to come up, which you don't have much to offer through DBS. So that's how I look at it. I tell patients your motors will control. I cannot tell you what will happen to the other side of the equation and how long you'll be able to maintain a quality of life. Although if they're not demented at the time of surgery, they tend to get good, I would say 5 to 10 years, around 8 to 10 years, unless something unforeseeable happens before the non-motor aspect of the disease really makes them disabled. That's how I would look at it. I wouldn't call it effectiveness of DBS. I think its therapy continues to remain effective. It's just the other part of the disease becomes quite burdensome, So they cannot feel the appreciation of the motor control as they used to feel 5-8 years ago.
One question also asking about what is left to offer once DBS plus drug combo has become ineffective.
Well, then it's du'as and prayers. If you have a patient who had DBS and now, so in most patients, the effectiveness issue is not going to be from the motor side, it's going to be on the non-motor side, and you don't have much to do there. But if the issue is of the motor, that somehow the DBS is not controlling their motor symptoms, then there is now growing trend and practice to combine a pump therapy with it. So there is now case reports coming up where there are people who have done DBS and didn't have much control of the symptoms, and then they ended up doing one of the pump therapies to see if they can control it. There's also evidence or case reports, it's not something we practice. If you have implanted leads in one nucleus, then you can go after implanting a lead in another nucleus if you really have one motor symptom that is it's not controlled. For example, dyskinesias. If your STN lead doesn't have that level of control, you can go to a GPI lead to see to accomplish it. So there are, in case by case, some elements you can consider, but by and large, it's the non-motor aspect of the disease which makes the whole therapy look ineffective or not too promising. In that case, you can't do anything. With the others, if you have the options and the patients can afford it or the system can afford it, whatever that is, then there is some growing practice to add a pump to these DBS therapies where they're suboptimal now after a few years.
Okay, thank you. Can you define the mini fluctuation? What mini fluctuation?
Yeah, so it's not a concept that is yet well published or understood. And what I meant by showing you the idea of the mini fluctuations is that even when we consider the larger motor fluctuations that you saw in all of the presentations, when patients take their medication, they go to a point of best response and then they go down. Even when we look at those curves, within these curves, which look very plain and simple and they look very beautiful, patients are not responding as A to B. They're not going up all the time. They're fluctuating. So even though they're going from, let's say, from Cairo to Sud or another city, but they're zigzagging. They're going up and down. It's not a straight road as we like to think with the ons and off. So it's not like they take the medication and they have a very nice flight and they're going to go to the peak, which is on, and then they're going to come down. The mini fluctuation idea is that they are even within that point A to point B change. They're fluctuating that we cannot appreciate yet because that's happening every 10, 20, 30 minutes. And that's a concept that is now coming up in terms of understanding these, not only the major fluctuations, but also the mini fluctuations that are not readily seen or observed in clinical practice, or we don't have a way yet to estimate them or assess them with the tools we have currently. So that's what I would think an easy way to understand these mini fluctuations would mean.
Could it be related to the cognitive reserve, to the dual task dysfunction in those with Parkinson's disease, or it may be related to fatigue that the patient can experience with minor or minimal effort?
So you raise a very good point. When you're assessing these patients, there could be the element of fatigue that may have an impact on the score. But I think by and large that is there, and we yet don't know how to sort of disassociate that with the actual motor performance. But in large, I think that there is the element of the drug therapy, which is something we understand in the larger fluctuations that is probably happening at the micro level as well. Because we do know that there's probably a lot of plasma fluctuation in L-DOPA levels, blood-brain barrier. So how of the pharmacokinetics of the drug work in controlling flux or response? How do the disease state works? Or is it just a combination of many factors, including what you're saying, the cognitive or the fatigue element. We don't understand that. But I think there's a general sort of agreement or a conceptual thought process now that these fluctuations that we see in the later stage of the disease are probably even happening in subtle ways. So it's just like the simple concept of water over the dam. So when we see the water overflowing the dam, that's when the flood comes. And then everybody can see the flood is here. But I think it's the reserves before the dam, the water is still up and down. And I think these are those kind of problems that we're now trying to understand before the actual fluctuations are coming in. Because it probably doesn't happen overnight. It's just not like, yes, you never had fluctuations for years and all of a sudden in the last month you're fluctuating. It means there was something building up. What is that building up? Is it these mini fluctuations or there's more to that? That's something we're trying to understand at this point.
Yeah, thank you. Question for Dr. Wafi. How common is sexual dysfunction in patients with Parkinson's disease, and how can we manage them? Dr. Wafi? Dr. Wafi, you hear me? Okay, tell Dr. Wafi.
أيوة. أنا آسف.
Did you hear my question? The question was about how can we detect, how common is sexual dysfunction in patients with Parkinson's disease, and how can we treat them?
There's a problem in self-reported symptoms regarding to the sexual dysfunctions in Parkinson's disease, mostly due to cultural and legal factors. The sexual dysfunction in Parkinson's disease may be related to decreased potence and decreased libido, which can be improved by sildenafil or other molecules like apomorphine. But the problem is the dopamine related hypersexuality, which is one of the impulse controls behavioral disturbances, and it is now can be controlled by atypical antipsychotics like clozapine or quetiapine.
Yeah, okay. For Dr. Anwar?
Yes, Dr. Fatem?
Kindly, can you outline the risk factors in developing motor complications in patients with idiopathic Parkinson's disease? Yeah, just outlining the risk factors for developing motor complications.
Risk factors, number one is the age of the patient.
Yeah.
Number two is the early non-motor manifestation. Number three, early presentation, early age of onset of the disease lead to more complication and more occurrence of levodopa dyskinesia and fluctuations. Number two is the early non-motor manifestation. Number four is the comorbid diseases with the patient from the start, which may limit the use of drugs or may lead to complication and the narrow spectrum of use of L-dopa or dopamine agonist. Number four may be related to socioeconomic of the patient, as the selection of drugs may cost the patient as selection of dopamine agonist for starting drugs. I think risk factors like age of the patient, comorbidities, early onset, comorbid with the patient cognitive disturbances or non-motor manifestation. Yes.
Can it be related to how the patient is taking or dealing with levodopa doses, like holiday treatment, like
yes,
over dopamine dysregulation syndrome, or what, like something like that in taking his levodopa?
Yes, with the occurrence of complications like dysregulation syndrome, we can do holiday in like 2 days off of the disease, of the drugs, L-dopa, or fragment the dose of the L-dopa for the activity of the patient at the day, and the may holiday at the night for the delay complication, or the use of sustained release drugs maybe.
Okay. So Dr.
Yes.
Bazwa, is there any gene therapy research in in Parkinson's disease management?
Yes. Over the last 2 decades, there have been tremendous interest in cell-based therapies for Parkinson's. Some of them are related to gene therapy. Some of them are related to actual cell transplant therapy. So one has to think about these categories of therapies that have been evolving with Parkinson's. Some of the earlier trials were done back in the 90s, which failed, but there has been significant resurgence. Gene therapy trials over the last 10, 15 years have been at least 2 to my knowledge that went to phase 3 but didn't meet their primary endpoint. There's now another one, and I don't have it on the top of my head, that is in the US at the moment, that has just published their phase 2 data, and they're going into phase 3. So yes, there is a resurgence of gene therapy and cell-based therapies at large. You may all be aware of this New England Journal case report that was published a month ago on a very high donor that was able to get a pluripotent cell transplant into his Parkinson's, and they've been looking at that outcome for 3 years and show improvement in the UPDRS and no worsening as baseline. So again, yes, but currently they're all in research, not clinically approved, and not being done outside of the research protocol. But yeah, there is a gene therapy trial, at least one that I'm aware of. There may be a second one, but there is no currently phase 3 trials for cell-based therapies or cell transplant therapy. I think that you will see probably in the next 5 to 10 years coming to the main sort of clinical phase 3 marketing. So that's simply what I can tell you at this point.
I hope we can be a part of this research in our MENA region. Hoping that.
Yeah, I hope so too, but generally these decisions and the processes are decided in lands further than us. So it's hard to entertain them or to incite them to come this far. But I hope someday the drug companies, device companies, or nonprofit organizations will think about us to invest in our region as well.
Okay, another question related to the cost of the DBS. The question was about any effort to make the equipments of the DBS cheaper. In case A, I think most of the patients are sponsored by the government, but if they are paying by their own, how much does it cost to do DBS in your center?
So the numbers vary from region to region and somewhat country to country. So the way I put it out there, the cheapest right now DBS globally is the Chinese ones. They're about 1/2 of the cost of the actual. So if let's say your Medtronic lead would be $18,000, $20,000, which is where the Europeans and the others are, but this could vary because they can sell this at a different price if it's a patient buying it, but then the price is very different if it is a government or a hospital buying it. So again, the numbers are not consistent and they don't reveal their pricing. But generally, like some example, if you go to Turkey, you can find most places offer you the full package for $25,000. If you go to other countries, Pakistan example, it would be less than $20,000. So, but the devices, if you want to talk about what's the one that gives the most sort of cost effectiveness, is the Chinese. That's somewhere between $10,000 to $12,000 at this point. So they're the cheapest around. again, which is from China. But so far, I haven't heard anything negative from patients who have been implanted or sites who've been doing it. So that may be an alternative at the moment till there's much more. Now, keep in mind that most of these international companies, Medtronic, Boston's, and others, have cheaper versions. They just don't market it. They have low-cost versions, but they just don't market it because they don't want to dilute the market with two of their products which compete against each other. But they have the technology, lower cost, to be able to do it. And I think Chinese just did that. That's why nobody's going to let Chinese come out that easily. But again, if you're talking about expected 25,000 plus and minus on average cost for the entire surgery, maybe a little less if you're in another country, maybe a little more if you're in a different country, but that would be the ballpark figure at this point.
Yeah. Thank you all speakers joined us tonight. Thank you, Dr. 𝐤𝐲𝐲. Thank you, Dr. Wafi. Thank you, Dr. Anwar. Kindly, for all attendees, there will be an online survey for the meeting. Kindly take just 5 minutes to fill it in the link on the chat bar. And now the floor will be with Dr. Tamawi for saying
you all and with our society. And Dr. Magid, you would like to say something?
Thank you very much for very nice and successful session, and I hope to keep on with our eminent speakers. Thank you very much, and see you soon face to face, inshallah. Thank you.